through. So you always make sure you hook up to your gas source, make sure you turn it on, always make sure it's plugged in too. So we're just gonna press that power button and give it a minute.
Is Kingwood using these too?
Yes.
Because we didn't use these in our class.
Oh, yeah. No,
I've
we're
never
using.
seen one of these before.
Oh, really? We use them as transport, so we have the C1s, 2s, and 3s. We also have LTVs and Parapacks. So we'll use a Kingwood. Alright, so one of the first things that you'll want to do, of course, after you clean everything and you get a whole new, brand new circuit, is you want to do your pre-op check. So this button right over here will say pre-op check. Go ahead and hit that, and you're going to go through these 3 steps. Just make sure you got your flow sensor hooked up correctly. So it's color coded, so you have clear and you have blue. We always make sure that we have a bacterial filter here, and then we connect our vent. Your flow sensor will go here.
Is there any difference between those two?
On which one?
The blue ones?
So this one's gonna be your inspiratory, and this is gonna be your
Yeah, I mean
expiratory.
between the, if we hook this tube into that or that tube into
No,
that.
no, 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 because it basically goes to the
That's
wire.
what I was saying.
Yeah, the only time you're gonna have an issue is if you were having a heater that's actually connected, because then you need to make sure you have inspiratory going all the way through, or your inspiratory will go straight to your expiratory, and that won't work. But on this one, as long as it's connected just like this, you're good. So when you do your pre-op check, you're gonna do your first one, which, all right, I'm just gonna, here. Let me grab a glove real quick, sorry. I didn't wanna put my hand over the end of that clean flow sensor. So the first thing you're gonna do is you're gonna check your tightness. So you're gonna click your tightness, and you're just gonna follow the directions. It says disconnect patient, and it's gonna say tighten your patient system. So normally there's a cap that will come with these in the package. It has like a little red end to it. You can use that. I didn't see it. It'll say connect your patient, just keep letting it go. And there you go. As long as you got your green check and today's date and time, then you're good. That means you passed it. So next you're gonna go to your flow sensor. So, that's all right. Okay. So whenever you pull out your flow sensor, there's usually a little plastic cap. You can use that. It makes it a little bit easier, but if you don't have it, all you gotta do is just hold it still. So you hit your flow sensor, it'll tell you to disconnect your patient, and then it'll tell you to turn your flow sensor. All you're gonna do is just kind of match it up and turn it. And it's gonna run through the cycles of the flow. It's gonna start low and then it's gonna go high. And you'll hear it. Oh, let me figure out why we're not passing. It's HME. There you go.
We're supposed to do this, what, like once a shift, or we're doing this every single
No,
time?
it's every single time.
Before
Yeah.
we hook it up to a patient?
Yes. And the reason is because you're trying to make sure that the flow sensor you put on is
Yeah.
correct, and you're also trying to make sure that the circuit that you put on doesn't have any leaks in it and it's correct as well. So the HME stopped the flow from going through. So right here, you're just gonna turn it back through, and you just wait to do it again.
How did you know when it was ready?
Yeah, did it tell you to flip it back?
It did. It said turn flow sensor.
Okay.
Okay.
So if you miss it and you don't see it, it's gonna automatically say it failed. So just rerun it again and just make sure you pay attention, but it'll always ask you to flip it both ways. And so we have it checked, we're good. So the last thing we always check is our O2 cell. We just wanna make sure that the O2 cell inside the vent is working properly. And so this one takes a little bit of time. Okay, does anyone have any questions over any of that?
So typically if we're gonna vet somebody,
Mm-hmm.
we don't know
I mean, if,
So should we?
this is what we normally do.
Yeah, we get it ready at the beginning of our shift and.
Normally, yes. Normally what we'll do is, after I've used it, I'm gonna clean it. I'm gonna get everything brand new. I'm gonna run my EST. I'm gonna run my pre-op check completely through.
Right.
If everything passes, once I'm good, I can bag this and it's good.
Um,
But if it's dirty, you really do have to run that check. You can bag a patient until this thing is done, you know? So, just because once you put the patient on, you're gonna hit so many alarms and you're not gonna understand why, and it could be because the flow sensor was bad or the circuit was bad.
So you took this thing off,
It's the HME, yes.
what is that?
So that's gonna add humidification to the circuit. So basically, we don't have heaters, or we do, but this one does not have a heater that you put on. We don't normally just stick every patient directly onto a heater, but they still need some type of moisture. So that's what the HME allows. It gives some type of moisture, so, because remember, oxygen's a dry gas. So after a while, that becomes very irritating, kind of like when people have a nasal cannula on and it's running for several days, they start to get nosebleeds and cracks. We don't want the same thing to happen inside the lungs. We don't want it to get irritated and dry. So that's why we always either keep an HME on or we'll put a heater on it.
But to run the checks, you pull that off.
Yeah, to run the check, pull it off. All right, so you're good to go. So as long as you have all your checks, then you're good to go. And you can X out of this one, which would be that little button right here. And then you can go into your modes. So if you have a patient, you get a patient in, you're intubating them, it's an adult, say it's a male, approximately, let's say around 185, maybe say they're like, 5'8", right? So we're gonna go ahead and we know the patient is intubated, so they're knocked out, we're not getting anything from them. I'm usually gonna pick a mode like AC mode, the CMV mode. What this is gonna allow me to do is I'm going to choose everything that happens, right? The patient isn't going to choose. So even if the patient initiates a breath, they're still gonna get the full volume that I pick. So for instance, so I'm gonna confirm that one, I'm gonna leave it on a rate of 12, go down to 500. All right, so what I would normally do is I'm gonna do an ideal body weight. I'm gonna determine off of their height what my range for my tidal volume is going to be. So we're gonna say that 500 was correct, so we're gonna go with 500. I'm usually gonna start with a PEEP of 5 unless I'm noticing that my patient is having difficulty oxygenating when I'm bagging. So if I'm bagging, I'm needing to add a PEEP valve, or I cannot get my sats up, then even on 100% PEEP of 5, most likely that's not gonna help. So what I'm gonna do is I'm gonna dial up that PEEP just a little bit. I always move
What
this.
increments would you dial that up?
So it really kind of depends on how they're oxygenating. It really, you have to look at the SAT and kind of look at your patient. And if you're running an ABG, that's a really good way to know, because once you get that PaO2, you're gonna know, okay, because sometimes my PaO2 will be really low. In that case, I would probably jump from 5 to 10. But in most cases, I'm probably gonna go from 5 to 8, 8 to 10, 10 to 12, 12 to 15. That's usually what I do. I kind of just step it up. And then always give your patient time to respond, because you're gonna make a change and they're not gonna respond right away. It's gonna take just a little bit of time, just kind of let the vent work, let them get some breaths, and then you should start to see the SAT go up, okay? And I do the same thing whenever I'm titrating the PEEP back down, because sometimes, especially in a code situation, I just need to open the lungs, but then once I have the lungs open, I can go back down. That patient doesn't necessarily need the 8 or 10 of PEEP. We just needed it initially to open up the lungs. Okay. Oh. And think about this one too, if you don't finish what you're doing, it will automatically kick you back out. So I'm gonna just start a PEEP of 5. We're gonna say that the patient needs to be on 100%, but I'm just gonna put it on 21 just for now, okay? So for my flow trigger, I usually, on the Hamiltons, I'll turn it down to 2. Makes it a little bit easier for the patient to breathe. 5 can be a little difficult, so especially when the patient starts to wake up. Okay, so I usually go down a little bit. And this is the flow that's required to trigger the breath. Okay. And then I'm gonna look at my I to E time. So right now off of 12, my I time is 1 second, which is appropriate, so I would leave it there. And then I would hit confirm. Any questions on that? No? So whenever you go to place it on the patient, you're gonna start ventilation. And another thing you're gonna notice is that your alarms are probably gonna go off. On these Hamilton vents, the alarms are set really tight, like really tight. It will not allow your patient to breathe. It will stop them constantly. So what you'll need to do is increase. I usually start with a preset. I usually do,
What do you
these are
increase?
mine, I'm gonna be honest with you, these are mine. Do what?
What do you increase?
Right now, the peak pressure. So for the way I usually do it whenever I start a patient, I will put my peak pressure to 55/5. I will usually do my minute ventilation to 24/2. And then I keep my rate 40/5. My tidal volume, if I'm set to 500, I'm gonna go to about 1200. And I'm gonna do 200, because anything below 200, I really wanna know. And I keep my apnea setting at 20. These are like my starting points. This to me tells me, okay, after I get a few breaths from my patients, then I will adjust my alarms appropriate for that patient. But just to start, I wanna make sure I give them enough space to take a breath if they're taking a spontaneous breath. Also wanna make sure kind of where my alarm settings are. If I'm having to go too high on my peak pressure, saying I'm hitting around 60, then I may either want to, if it could be either sedation's an issue, like if the patient's fighting back against the vent, or it could be a lung issue, meaning that I'll either need to change the mode on the vent to try to help with those higher peak pressures. Does that make sense? Any questions? No? Okay. So whenever your vent is running, this is what you're gonna see on the patient. So right now, my patient is not breathing over, so every breath is going to be a mandatory breath. So this patient is breathing 12 breaths, 500 tidal volume approximately every single time. Okay. And then you're gonna see that it will recalculate itself, and it will kind of I don't know exactly how many cycles it is, but it will go through these cycles where all of a sudden you'll see things kind of dash out. It's because the vent itself is recycling and kind of adjusting itself. When you want to see all of your values of what you're getting from the patient, there's this left tab down here at the bottom called monitoring. You're going to click that monitoring tab. This is going to bring up everything: your peak pressures, your mean, your PEEP, your FiO2, your exhale tidal volume, your respiratory rate, and your minute ventilation. So everything's going to be here. So whenever you're doing charting, or if you're trying to see what's going on, if I'm delivering 500, I want to make sure that my exhale tidal volume is close to that. Usually for me, I usually do about 30, give or take. So as long as, because usually breaths are going to fluctuate. So as long as I don't drop below that. If I'm dropping below 50, then there's an issue. There's a leak somewhere, something's happening. So I might want to check the cuff, but I'm losing air somewhere. And let's see, so any questions on any of that? Okay, so if my patient was to be breathing more, you are gonna see so it'll go a little bit more. So basically you're gonna be set to 12 and you're gonna be breathing whatever it is. If my peak pressure starts to go up and it's gonna hit my alarms, hit the alarm, I might have to lower it a little bit. So when I start to hit my pressure limit, it's gonna tell you. So basically what that's telling me is that I'm hitting my pressure and it can't go any further. So it's not able to deliver my breath because my volumes are gonna get lower too. So one of two things could be happening there. It's either gonna be a lung issue or your alarms are set too close to the patient and they're not able to breathe. Especially when you have a patient when you're doing everything, it's not gonna alarm as much. But when you have a patient that is breathing and going against the vent, it's gonna start to fight with it. And once it starts to fight with it, the vent's gonna start cutting off the patient's breath. So another thing is sometimes things get disconnected. Sometimes there'll be a leak. This one is one of my favorite ones. It loves to disconnect. Let's see if it's gonna do it. Oh, it's not gonna do it. I might have it set too high. But normally, once you start hearing anything, or once you start to get a leak, on a patient's a little different. Right now, on my perfect lung, it's not really doing anything because my lung just keeps expanding, basically. But that will be one leak that will happen. Sorry, that didn't do anything. And this is another issue that will happen whenever you disconnect these. So once it starts losing flow, or what it thinks is flow, it's gonna mess up and it's gonna start telling you that it's not getting anything. So you're gonna be looking at your patient thinking, oh, are we extubated? What happened? And everything looks perfectly fine. Start looking back through your circuit, because a lot of times these or one of these will get pulled out. Okay. And so there are a couple different modes on here. If you go up here to modes, you also have an SIMV mode, and then you also have all your pressure control modes, including spontaneous. So I don't know how often y'all use those, but SIMV basically allows the patient to breathe a little bit more. So what you're gonna do is you're gonna set a pressure support, not 30.
I'm not gonna lie, you're speaking straight to me.
Oh no, I'm sorry.
I don't know any of that.
So what pressure support does is it allows, when the patient takes their own spontaneous breath, what pressure support does is it gives it a little boost to kind of compensate for going through the tube, makes it a little bit easier for the patient to breathe, more like breathing normally versus trying to breathe through a straw. That's what pressure support does. And so the only difference between here is, like I said, every breath that's the normal breath that's supposed to be delivered, all 12 breaths will be delivered at 500, but the spontaneous breaths are gonna be just a little pressure support, so those volumes will change. So you may see most of your breaths being around 480, 500, and then all of a sudden you'll see like a few around 300. That's your patient taking their own individual breath. Okay. Any questions on anything?
BiPAP?
BiPAP. So whenever you're doing BiPAP through here, do you do BiPAP through here a lot? So you're gonna go to your non-invasive mode, NIMV-ST, and hit confirm. What this is gonna allow you to do is do an inspiratory pressure and an expiratory pressure, okay? So say I wanted to set my BiPAP to 12/5, I'm gonna deliver 21%, I wanna set a rate of 12, an I time of 1, that seems about right. So I'm gonna hit confirm. And so what this is gonna do is it's gonna be BiPAP. So when you're here, you should be set up to your mask.
I was fixing to say, where is the mask for this one?
Do you have a mask?
There.
We couldn't find a mask for that one day.
No, we have those silver ones that won't go.
Yeah.
Smush them
Yeah, there you go.
together.
So I don't
And
really
that
wanna
is the
open
CPAP
it,
and
but
BiPAP.
this is gonna be BiPAP. If you wanna do CPAP on this one.
You just click over to CPAP.
Yeah, cause it won't let me go any further on this one. So what I would do is I would go over here to modes and go to NIV. And on this one, you should be able to turn this off. You'll have to turn your pressure support all the way off, and then it'll allow you to do just a CPAP of 5, 8, 10, whatever the patient needs. And then you just confirm.
Same mask.
Same mask, same mask. Okay. Any other questions? I don't know what else y'all use it for. It's just the BiPAP mode, CPAP mode, and then just intubations?
Yes, we just, I think a lot of that for me is a lot. I just need to know what to do to that patient when they come in and we intubate and put them on. Because we're going to be getting them out as soon as possible, so all
Right.
that extra stuff is just confusing for me.
Okay.
I don't know if anybody else, but for me, I just need to know what I need to do when we intubate and get them on the vent.
Yeah, because
Which
if they
is-
go on a
yeah.
vent, we're calling for emergency transport too.
Okay.
We're not gonna give a.
We appreciate you doing all that.
Yeah.
We're like, ugh.
Yeah, the thing is though, putting them on the vent is everything I just said. It is setting the rate, it's setting appropriate tidal volume, it's setting the PEEP, it's setting the FiO2 and the I time and the flow. That is putting the patient on the vent.
So a while ago, you were messing with the settings and you said that sounds about right. So is there like, for an average sized person, like a specific
There-
setting amount that we
there-
could start them at?
So it's based on height.
Height.
So really what it is you'll need your ideal body weight. So,
And
which,
your physician will give you the title.
and
block
most,
that they want.
oh, okay, so most likely then if they're gonna do that, then you'll just plug.
Our docs will typically say this tidal volume, this P.
Oh,
Yeah.
perfect then.
They'll tell
Then in
us
that
and we can
case,
just make
yeah.
our settings.
So then in that case, what you'll do is you're gonna most likely, if you have an intubated patient, it's gonna be CMV. We're not gonna want them, because they're
Right.
usually not breathing on their own,
No,
strictly
we've
CMV.
paralyzed them, so they're not.
Exactly.
So my question is, okay, the numbers that the doctor gave you, what would, I come in here and say those aren't working, what would I be looking at to say, hey, doc, those aren't working? What do I need to change? What would you like me to
So
change?
really, in order to know if your vent settings aren't working, it's gonna be a gas, an ABG. So when you look at your ABG,
Okay.
depending on what the values are, if your CO2 is really high and your pH is acidotic and really low,
Right.
then something's going on. It's either my rate needs to be increased or my tidal
There's
volume needs to be
nothing in here I
increased.
can look at that is like, is it?
Not necessarily unless it's oxygenation. So if it's oxygenation that's the issue, then you're gonna see your SAT. So if your SAT says it's 80,
Right.
then, and you're on a PEEPA 5 100%, then that tells me that you need to go to the doctor and be like, hey, I think I need to increase this PEEP because my SAT's still saying 80. We usually try to correlate it to a gas just to be on the safe side because, you know, sometimes this is a little off.
So PEEP is what I would increase?
PEEP is what you would increase.
Okay.
Mhm.
Okay.
And then according to the gas, if the CO2 is high, you're either gonna increase your respiratory rate or your tidal volume.
Gotcha. Yeah,
So
that makes sense.
so for ventilation, it'll be respiratory rate, tidal volume. For oxygenation, it's gonna be your PEEP and FiO2.
I think that's.
And I've had
Okay.
issues with specific doctors where it would not stop alarming.
Yeah.
No matter what I did.
That's our issue, really.
But, and then the doctor was frustrated because we couldn't fix the alarms and it came out to be the tube wasn't in the correct position. Once the x-ray was done, they adjusted it, all the
Right
alarms
mainstemmed.
stopped. Everything stopped.
Yeah.
So that will happen a lot of times too, if the tube is right main stemmed, meaning it's too far down.
I think that's what it
So
was.
your x-rays are really
Right.
important too, because what's happening is all that volume is going to just one side. It's not going to the other side, which is the reason why the vent, no matter what you do, everything looks perfect, the patient looks perfect, you can't figure it out, I'd always get an x-ray. Because most likely, it's gonna be too far down into the lungs, it just needs to be pulled back out.
Nice.
Or also check those alarm settings. Because remember, every time you turn this off and you turn it back on, it is going to reset all of these settings back. So that's why I usually open them up, get my patient on it, and then I'll close them up a little bit once I have my patient on. I always try to give them a little bit of room so if they cough, if they start to wake up. But most likely for y'all, they're just sedated, so you could lower those alarms so that way, tighten them up a little bit so you'll know when it alarms, that means something's wrong, meaning I'm not getting a volume.
Okay, makes sense.
So it goes back to the standard setting.
Standard, every single time.
I think that's what I'm doing wrong, is, because when mine beeps like that, I think that's the last time that we messed with those modes.
Okay, so yeah, a lot of times that's where I would go first, is look at my alarms. Because remember that it's gonna drop these pressure
Does it
alarms, it's gonna
tell
drop
you?
everything.
It'll tell you which
Yeah.
one's alarming
It'll-
too.
yeah, it'll
You'll
say-
see,
Oh, okay.
It'll
you'll
say
see
it
the
right
little,
across the top.
Okay.
but also in the little area where it'll be lighting up, like you'll see the red coming up.
So it's gonna tell me to change it, or?
Yeah, what it's gonna, see, whenever this lights up yellow, and that line's trying to go up, what it's telling you is this pressure's too low, I can't go any higher.
Okay.
So then you'll know by looking at, oh, this is the one I need to increase, and you'll increase it a little bit.
Okay. That
And then you'll
helps
try
a
to,
lot.
yeah, catch the patient. Thank you for telling me. I
think that's
didn't think
mainly
about y'all
what-
only
what
have
our
it
issue
intubated
is.
and
The alarm.
sedated.
Yeah.
We can get them on the bits, but once we get everything settled, it's like alarm, 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 alarm.
Yeah.
So that's.
I
where
would
we should
always
go.
check my alarms first
Mhm.
and make sure an x-ray happens.
Well, ours here, it always says this battery replacement, and so it
Yeah.
always beeps that too, and I don't.
Because it needs to be replaced, so it probably needs to go back to biomed.
We've asked forever. I mean, I don't know how, like,
I'll reach
because
out
every
to
time you turn it on, in fact, I think they even sent somebody out, didn't they? And they're like, oh, it's.
Yeah, they did send some out, and everybody's like, it's like, oh, it's fine.
Yeah, but it's like, it'll constantly alarm when the patient's actually hooked up, and that's the only thing that's alarming.
Oh, so this is actually it does not belong to us.
That's why
So
I
this
want.
is a rental, so what I need to do is reach out to Horatio at Peak, and what he'll do is he'll have to come out and get it, and I'll have to see if he has one where he can flip it out.
Is that like the other one though? Is that like yours?
Yeah.
Okay.
Mhm. Oh, yeah, we have these too, but this one just happens to belong to Peak. That's probably
Okay.
why, if you were calling out biomed, they can't touch this.
Right, that's probably what happened then. Yeah.
So I can send a message out that way and let them know, because basically what this is telling me, normally down here at the bottom, there should be 2 little batteries, 1, 2. So right now, this one's running off of 1.
Right.
So whenever you unplug this, you're only gonna have 1 backup battery versus the 2, which will run a little bit faster. So I'd make sure it's plugged in, and I'll reach out to Peak.
Okay, thank you.
Yeah, you're welcome.